Good afternoon, everyone. Thank you again for joining us for this week's edition of the New Hampshire COVID Alliance meeting. Again, for those who are new, the mission that we developed with the Division of Public Health Services months ago was to convene stakeholders in New Hampshire to promote vaccine confidence, support accurate, consistent vaccine messaging, and foster coordination of the Vaccines Alliance. To do that, we have three goals: to promote public buy-in, to increase immunization rates, most importantly, to act as a force multiplier, to support the COVID-19 vaccine communications and allocations plan of the division. Also, to counter misinformation on the COVID-19 vaccines and foster use of the immunization information system, which we'll be discussing a little bit more today. Next slide, please. A couple items, just keep scrolling through a little bit more. There we go. So these are recent discussions, typically that occurred over the last couple of weeks. People have asked about them, and if you'd like to hear those recordings or see the slide decks from either of those presentations, you can find them on the Medical Society's website under News Blogs. Thank you. Some takeaways from this past week, beginning on Monday, out-of-state college students, people with vacation homes visiting, essentially anyone can register for vaccinations, COVID vaccinations in the state, but you have to do so through VINI on the website there. The mandate expired last week, but cities, businesses, and schools can still continue to enforce mask mandates. The governor said he still supports those, and we'll be talking about another item later in this meeting about that. The Safer at Home guidance is scheduled to end on May 7th, and reopening task force will revise general best practice guidance document. Next slide. Also, what we discussed is preparing for the allocation transition from a predominantly public allocation system to a private process as the demand decreases. And to be able to do that, we said a couple of things that you want to make sure you have ready to go. And the first one, which we're going to discuss on the New Hampshire IIS, make sure you have your workflows in order, have information for patients, and then there's other messaging promotion sites where you can get more ideas to promote vaccines at your practice or facility. The next thing that all providers will have to have if they want to be able to distribute vaccine is to have signed a vaccination provider agreement. And so you can find this on the vaccine information site of the department. It's laid out here. Only twist in this is you have to download, update, open the document in Adobe Acrobat and complete it in the web. Do not complete it in the web browser, and then you have to send it into C19 enrollment at dhhs.nh.gov. Next slide. Here are a copy. If you go to the website and other locations, you'll find a copy of the brandable vaccine FAQs that are available that you can take, amend as you see fit, brand them as you would like. Next. Now, to our discussion today, I'd like to invite Beth Daly and Alok Patra to talk a little bit more, give us an update of where we're at with the reopening of the New Hampshire Immunization Information System. Tell us a little bit what you're at, what you're kind of hearing back, if there's any changes from original guidance that might have been issued earlier. Welcome, Beth. Thank you for joining us today. We really do appreciate it.
Great. Well, good afternoon, everyone. Thanks for having us, and thanks for all you do, all the partners do to support the COVID-19 vaccine and COVID-19 response in general. So really appreciate that. And I'm going to quickly turn it over to Alok Patra, who is our IIS program manager here at the State Health Department, who's been rolling out all of our technology that's supporting our regular immunization program activities, as well as the COVID-19 vaccination activities as well. And in particular today, I think we're going to talk about standing up our immunization information system, what that means to our healthcare provider community, and where we're at in terms of that rollout. You'll also see TW, or Terrain Hall, here as well, who's leading our COVID-19 vaccine operations too, and he's joined in case he can support answering any questions you might have. So with that, I'll turn it over to Alok.
Good afternoon, everyone. So a couple of updates that we rolled it out in the last 2 weeks. As you all know that we are using the Winnie for our statewide scheduling and the registering system and the patient vaccination documentation system. And we are continuously doing the improvements onto that one so that it can be helpful for the provider out there. And with the newest enhancement that we have been hearing from the field and the requirement that is coming from our operation teams, one of the significant items that we added, as you know, on 4/19, we open up the Winnie for all resident outside of New Hampshire, and we are tracking that one. Over the weekend, we also made a good amount of changes to the system. And one of the things that came from the operation team, that if it is less than 18-year-old, the parent or the person who is registering that vaccine recipient for the COVID vaccine has to give a consent. So that particular part is there as long. So we are going to track all those items, and in a future release over the weekend, we are going to add another enhancement to the Winnie application, that if a patient is below 18, the system is going to flag them at the time of when you're logging the vaccine, saying that the patient is below 18 and the consent has been taken or not taken. So the vaccine administrator would have a two-phase information at there that the patient is 18 and they should not be adding any kind of should not be adding the vaccine that is not recommended to that age group. And the second is that the consent has not been taken at the time of registration. So that means the vaccinator has to take that consent at that point. So few of those items is going to be added up pretty soon. So that is pretty much a very brief update about the significant releases coming in the Winnie. And along with that, very cosmetic wise, we're going to have added a lot of different items to the Winnie, and we'll continuously going to add more and more items to that. One of the resources that we heard also, that if people wants to know what are the new updates that has been coming in, and we always direct them to our Winnie newsletter that we send it on Thursday and Friday. So if anybody wants to know the changes that is happening with the Winnie, with the trainings, with the newest updates, all those different other items, then the Winnie newsletter is going to be the one-stop resource for you. And if you want to hear about that one and you are not part of that distribution list at this point, we would request that you send us an email to our nhis.support@dhhs.nh.gov email address with a subject line that you want to be the part of the distribution list, and we're going to add you to that list, and you will get to hear from us in our weekly newsletter. So that is with the Winnie. The second part with the IIS, as you know, on 15th of April, we open up our state IIS, which is, thank you, Beth. So we open up the IIS for all non-COVID related, vaccine ordering to patient documentations with our IIS. The people who are new to the call or maybe not aware of the history, that we always had an IIS system which is not fully functioning. And that IIS system was only being used to order the vaccines, but there was no patient documentation part of that IIS. So people are just ordering the vaccine and giving us, saying that there is no patient doses into there. There is no way that we can document or analyze any kind of coverage estimate or do any kind of HL7 interface with that. Back in the July 1st, 2020, we went with another contract with a newer vendor, and we started working up in a war footing method to have an IIS up and running. And now we open up the IIS for all non-COVID related vaccines ordering and patient documentation on 15th of April on that one. And when we opened up 15th of April, around 140 providers who completed the mandatory trainings got access to the IIS. And eventually over the period, we are already, over the last 4 days, we are already, added more providers who are completed the training and coming to the IIS. And we're going to keep doing that until we complete the whole 100%. We recognize that training takes time, so people are maybe want to take time to really understand what exactly IIS can do for them. So maybe there are a lot of questions are happening. People might be having some thought process into that, how this is going to be integrated into my business processes. So we understand that people are taking time, and we recognize that one, and we appreciate that people are taking time to think through put the whole everything, and we'll be here to support them. Along with the whole training process, any questions that anyone has with the IIS, with the trainings, or with any of those questions, we always do a office hours, Monday, Wednesday, Friday, from 12:30 to 1. If you want to know about that office hour and you have not received that invitation links, please send an email to that same support account that is there on the chat box. We will make sure that we'll send you that invite, and you can join there and ask any questions related to IIS, or if you have any questions to the training, or if you have any questions with, you are a current user already there, but you don't know how to do certain things. Please make sure that you join those ones so that we can have a direct one-to-one conversation with you. We can show you the screen how to do that, and we can walk you through the step-by-step guidances on that. With that, I would just stop right there. Then probably I will have some more questions on that one, and I'll be happy to answer that as we go along.
Great. Thank you very much, Alok and Beth. Just a couple of questions that we've already received from various clinical practices. The first one is, what are the mandatory vaccines that need to be reported in IIS?
So I'll start this, Alok, and then you can chime in here. So right now, the only mandatory reporting of vaccination at the state level is COVID-19 vaccine. Anyone who's administering COVID-19 vaccine is required to submit the patient level information, and there's no opportunity for the patients to opt out. Once the governor's emergency order expires, the state of emergency, I should say, then patients will have the opportunity to opt out or withdraw from the registry. But right now, all providers administering vaccines do have to report that into our state IIS or VINI or VAMS, one of those systems, so that it can be fed into the national data systems. The rest of the vaccines, from a statewide perspective, participation in the registry is voluntary on the part of the healthcare provider and on the part of the patient. However, with that said, in order to receive state-supplied vaccines, which is primarily right now through our childhood program, although we do universally purchase all childhood vaccines, there are some adult vaccines also. In order to acquire those vaccines and order them, there is now a dose-to-dose accountability, meaning you have to account for every dose that you administer of our state or federally supplied vaccine by entering that patient's information into the registry, unless they opt out. And then, so that means there's also the opt-out process that the providers are having to contend with now as well.
Great. So just to summarize, so if you're ordering a vaccine through the state, then you're required to essentially have all those doses documented, reported before you can order again. Is that right? And how about the other vaccines that are directly purchased from other suppliers? Do you want that information, or is that what's the status on that?
We do want that information. Obviously there's many benefits to having an immunization registry in place. We're the last state to implement one. So many benefits for healthcare, overall delivery, for public health, and also for the patients who will have access to a complete record of their immunization, no matter what provider or pharmacy they might go to. So it's really great for information exchange that improves patient care. So in order for that to work, we need to have as complete a registry as possible, which means that even if you're not required, because you're not getting your vaccines through us, maybe for your adults or whomever, we want you to participate in the registry and encourage your patients not to opt out.
Great. Thank you very much, Beth. Next question we have has to do with, when is the anticipated release of the HL7 code for EHR integrations?
So Alok, would you respond to that?
Yes, so we are planning to do that over the next coming weekend. Either it would be available Friday or over the weekend, then it will be there on the Monday. So it's just, that is the period that we will push that whole specification guide out there in our NHIAS website. And again, when we are going to have that, we'll possibly going to send an email to our all vaccine managers that saying that this is there. Possibly we're going to tell people to come to our website to get those guide. And when you get the guide, please make sure that when you are going to distribute that one, we will always, as a good rule of thumb in the future, in that you will always tell people to come to the website to get the guide, not attach that as a PDF, because specification guide documents subject to change. So if you're going to send it as an attachment and somebody is referring to that attachment where that attachment might be outdated and they will be working on some outdated document. So it is always a good that the website link that we're going to put, you send that website link to the all the partners or all the stakeholders that is needed to know about that one, and have that as a bookmarked, and come to that website whenever you need any kind of guidance or anything like that.
And I just want to add that HL7 messaging is what allows for you to just enter data, the provider in their EMR, and then to have that automated exchange of information where the data will come to us, so it doesn't have to be a duplicate entered. I just see a question here in the Q&A that I thought I'd answer related to that, which is talking about triplicate entry, NHIAS, EMR, and VINI. So you don't have to enter in both VINI and the IIS. They're all feeding the same data system. So if you're talking about COVID-19 vaccine, you only enter into one. And there's a question related to that then about accepting flat files. And the system is not going to accept flat files. We are only moving forward with HL7 messaging. So your two options are to data enter or to just establish that HL7 connection.
Terrific. You jumped right on my next two questions. Thank you, Beth. Another question here is, will there be any flexibility on the 7-day entry requirement, knowing that they have to, for any state vaccine, that they'll still have to get those all in before they order again?
Yeah, so we are going to be flexible on the 7-day entry requirement, which is in our administrative rules for this initial rollout. And we're going to actually issue a memo to that effect so that people don't have to be worried that they're not complying with rule. And the key here is that you have to enter the data before you make your next order. We recommended that everyone during the transition time order 4 to 6 weeks of vaccine, which will give you time to implement those processes and get your data entered in. And we will have this type of flexibility for the first several months of the rollout. And obviously over time, we want you to get more and more timely. I see there's another note in here just about how it takes more time initially because you have to enter that patient demographic information, which is true. But once you have that patient in the registry, then it's much quicker to just enter the vaccine dose and lot number, and it should go quicker for you going forward if that initial entry is tough. Fortunately for adults right now, we have hundreds of thousands of New Hampshire residents that are already in the IIS because they've received COVID vaccine. So if you're doing adult entry, that should go much quicker for you. But we know a lot of you are obviously dealing with children, and because we haven't administered COVID vaccine to children yet, all those kids are going to need to be entered into the registry.
Great, thanks, Beth. So we'll take some questions from our participants. So when do you anticipate having opt-out documents available in other languages? Is there a timeline for that availability of those resources?
So I'm not aware that Alok, do you have this on your radar?
Yes, we have that in the radar. We'll have that one. We'll have it in one language. We saw that couple of requests came to our support language in the different, but our main focus to have that document available in the Spanish language first, and then we'll see based upon the demand of other languages, we'll look into that one, but that is under the radar. And again, once it is available, we'll push it to the our providers, and we'll have it on our website as soon as possible.
Thank you. Another question, how can we get a clinic ID?
I believe that question's need some little bit more information on that one, but you can only get a clinic ID at this time if you're a current user of IIS. So your clinic ID will be there, but I believe the person who is asking that question is coming from the flat file upload process. At that point, you first have to, complete the enrollment form that is out there, and the instructions and the business processes is there in that instruction sheet. You need to complete that enrollment form first and send it to us. And once we have that form with us, and we're going to provide you instructions on your clinic IDs and the steps. And just like what we mentioned, that was for the flat file, and that flat file options only for the COVID-19 vaccinations, not for the regular vaccines. And the reason Beth said that we are not going to do the flat file, because it is a kind of like, as you are working with a flat file, we are going to open it up HL7 over the weekend. So you're going to also working on the HL7. So we want you to better utilize your resources and focus on the HL7 than on the flat file. So that is why we're going to phase it out, the flat file altogether. But we wanted to keep that options, because some of the provider we have there right now, they just want to do the COVID vaccines because they are maybe getting federal allocations. They don't do any kind of other vaccination, so we don't completely eliminate that process out. So there are a lot of different processes. Every clinic is different. Everyone's story is different. So that is why it is out there, because we got a question that if you want to work on HL7, why do you have flat file out there? So I just want to clarify that this is the reason, because there are some provider, they just want to give COVID vaccines, and they're not like a vaccinated provider, but they're just acting for the time period for the pandemic.
Thanks, Alok. I think what's important, can you take us kind of just top level through the process of HL7 messaging? I believe, isn't there some testing that's required that has to go back and forth between the department and each facility?
Yes. So the way that the processes work, again, every clinic has to enroll. Means if a parent organization have 50 clinics throughout the New Hampshire, then they have to complete 50 different enrollment forms, and we are going to test with each and individual locations. You might be asking, hey, we are using the same EHR, so why should you have to test it separately? But that is how, because every office has a different processes, and to make it much more cleaner, every person is different, how the data entry is being done is different. So to make it more very clean process, and again, with this whole process, the main word that you have to keep in consideration is the data quality. If your data quality is not good, we are not going to move you to the production, no matter how long it takes. So your data quality is something that we are going to prioritize again and again. So like I said, when you are going to put an enrollment form, you have to put the enrollment form for all your locations. And then we are going to invite you that, hey, we are ready for your stage 1 testing. Once the stage 1 testing is going to just to let us know that your EMR is capable enough to create one HL7 file. And there are a couple of test cases that we are going to give it to you. Say like, do this and do that and send us an HL7 file satisfying that conditions. Once you do that stage 1 testing, then we'll just going to pause right there, and then we're going to compile all your data. Then we're going to invite you for the stage 2 testing. In the stage 2 testing, your EMR is going to send us production data, your production data, to our test environment. It is not production to production. All your production data is coming to our test environment. And under test environment, we're going to compile your data for at least 30 to 45 days, and we're going to do a random checking on those data. It won't be any linear fashion or anything like that. We're going to pick up and choose for random data, so that we'll make sure that your EMR is sending quality data to us. And during that quality checking, we're going to check your data with our Delta guide that we are going to push it over the weekend, and make sure that the way that we asked you the data, your EMR is sending that way or not. If the EMR is not sending, we're going to create an audit file and send it back to you. And then you'll need to fix it and send the data again to us before we can move you ahead. So it is going to be a cyclic process, back and forth communications. And it's all depend on how quality your data is. If your data is very qualitative, then we're going to onboard you quicker. And once you are onboarded, means your production data coming to our production environment, we're going to keep you in the probation period. That probation period means we're going to we're going to treat you as if you are in our test environment, but you are actually connected to our production environment, because we want to make sure that once you're connected to production, it is because of the technology world, it is two different feed coming in. We just don't make sure that your data is not getting bad or something is missing. And once you are moved to the production, we're going to have a routine check. And during that process, anytime any problem happen, we're going to work with you and inform you that the problem is happening, and we'll request you to fix it. If you're not going to fix a problem and the issue is getting more and more, we're going to move you back to our test environment, because we don't want to compromise the data quality in the system. So it is a timely process, a time consuming process, and required a lot of communication between the DHHS and the provider side. So we would always request that you have dedicated people from your EMR who can promptly work on the issues, looking at the guide, looking at your feed and making sure there is nothing wrong, and continuously observing and keeping an eye on those different things that we asked you to do that.
Thank you, Alok. It's a very comprehensive answer. Thank you. That's very informative. Next question from our participants. If not all of our vaccine administrators are in the system yet, how do you document the vaccine? The vaccine administrator field is mandatory.
So that way we are asking, like, as we are talking to us through the different channels, through the emails or through the our office hour, we are asking you to give us all the vaccinator field name, and we're going to continuously add it. We had the document until as of September, when we kind of like move our data migration from our old system to new system. And that is why we kind of like gap of people that is supposed to be there but not there kind of thing. And also we also hear that some of those people are hiring new people to come into the system so that they can be the vaccinator. So we just ask you just work with us, send us those informations who needs to be the vaccinator field, and we'll just keep them adding to our system. And one thing that we just want to make sure that if you are bringing temporary people just to accommodate your business process, and that person leaves after for certain months, you are required to tell us that person leaves, because that person will have access to the certain things, and their name will be associated with the vaccine doses. So we just want to make sure that our data in the IIS is correct, the vaccinator name is correct. So anytime there is a change of staff process, you need to tell us immediately within 24 hours of that thing happens.
Very good. Next question is, how do we account for vaccines administered to children that are seen in our clinics that reside in Vermont and Massachusetts? Sticker, a stumper.
Sorry, I just trying to find that question actually. So if you are giving, so if that vaccine doses, ordered by us, but you are giving to the, Vermont, you still have to just simply add that patient into the IIS. IIS does allows you to add patient out of state. So I don't think that you are going to have any issues on that one, but please let me know if I'm missing something here or maybe misinterpreting the questions.
Okay, same participant says, our office is receiving documentation of COVID vaccines administered at pharmacies. These patients do not appear to be in the IIS yet. Should we be loading those in?
Yes, if you have vaccine doses, like Beth said, we would like to know if you have evidence of a vaccine doses and the patient is not being opting out. If you want to add those doses, it is highly recommended for the completion of the patient record. You should add all those doses to there. It's not just for COVID vaccines. If an adult comes to your clinic and they have, HPV or flu or anything that is taken at the pharmacies, but you see that the pharmacy has not reported, or maybe the patient record is not updated, you are free to add that doses to that system as an historical dose at that point. Beth, you wanted to add something to that?
Well, I just, so with the COVID vaccine, there could be a slight delay. I guess the concern is duplicate entry. They're talking about getting their COVID vaccine at a pharmacy. Maybe for whatever reason, it hasn't quite been entered in the system yet. If they do duplicate enter, is there some process behind the scenes that will manage duplicate entry like that?
Yes. Yes, so what will happen that if as a provider, there is always a delay of data coming to the IIS. And so what will happen that when we get the data into the system and you already added the doses, we'll just simply update the dose informations with the correct, with more accurate information if we have, or if it all things are matching, we are not going to change anything and we'll leave it alone. So the IIS has the capability of the deduplication of the patient and the doses.
So
Very
if the patient's presenting like the day after they got their vaccine, maybe that's just a delay issue because they should be reporting all those doses. But if it's, you know, months out or a month out or weeks out, it's probably okay to enter.
good. Thank you. Here's a question. I'll let you read it through from Christine Arsenault. I'll read it. Let you read through with me here. Pediatric practices are struggling with time that it takes to enter all this demographic information to the system. I am posing this question on behalf of Eric Schechler, the president of the New Hampshire chapter of the American Academy of Pediatrics. Since the state's desire for manual entry is part to aid inventory with the new vaccine ordering system, is it possible to advocate that what gets entered is the bare minimum for inventory purposes rather than the full demographic information for each patient? Could we could supplement the full demographic information once the electronic interface is operational? While the full gamut of information is necessary for a functional register, we don't have the registry information until we get the interface anyway.
So I think this question and the next three here in the Q&A are along the same lines, just asking why they can't just order the vaccine without entering in the dose accountability. But that's how the system that we have implemented works. That's what a registry is. And certainly it takes a long time to enter that information. I see Exeter in here has two comments that it takes them about 8 minutes to do a patient because they have to enter in all that demographic information, whereas it might only be 2 minutes if you're just entering the vaccine information itself. So this is the growing pains of implementing a registry, and we have the benefit of having learned from the experience of the 49 states who have come before us, and no state has complete HL7 messaging in place. There's always manual entry that's happening, duplicate entry, and it'd be great if we're going to know that we were going to have 100% HL7 messaging in place, but we're not. And it takes weeks, as you heard. Alok described the process for onboarding HL7 messaging. And we've already made the transition to use this new system. This is how it works. We have a lot of different reasons why we've had to make this transition now, immediately. And it has to do with contracts and funding and laws that support use of the registry. So we certainly understand that it's a burden for all of you out in the field, and we're going to offer as much flexibility as we can. Like I said, you have to reconcile your data before you can order vaccine again, but that should be hopefully for you a few weeks away. Alok, TW, did you want to add anything to that?
I'll let the TW go ahead, then I can just give a very practical scenarios from my lesson learned from all the 49 state. I just want to be very honest on that one. So TW, do you want to add something on that?
I think, can you guys hear me okay?
Yeah.
Great. I think these are the challenging growing pains, as Beth said, in terms of implementing a system like this. As a bedside nurse, I'm not wild about any time that I have to do duplicate data entry, but I think we can also, there's lots of times that I have to do that with Pyxis or another system that I'm working through in an office, whether it be provider or hospital that I've had to work in over the years, and that's not the ideal. We want to get through that, and we want to get to direct messaging that goes back and forth for HL7. I know that from the state side, we're doing everything that we can to maximize our resources to basically put into play to make that happen. But as Alok explained, that's a give and take, right? So we have to be ready, and you have to be ready to move the football down the field. So it's meeting the providers where they're at in terms of different areas to try and do that direct HL7 messaging as quickly as we can. I think we are in a unique situation in the fact that we can learn from the other states that have come before us. And if we all choose to prioritize that directly, then me and my other roles as a nurse, at the bedside would greatly appreciate that for whichever systems I'm working for at that time, right? Because we don't want to do additional burdens and additional areas and things like that. At the same time, New Hampshire has been able to go through for a little while without necessarily meeting CDC's criteria, right? So CDC and the federal government do pay for these vaccines to come in, and that's great in terms of a public health standpoint. In terms of doses coming in, the insurance companies obviously pay for the other portion of that in the state, and we're very grateful for that too. But that those payments also come with the understanding that there is benefits to having an IIS, and those agencies have requested, and even strongly more so in more recent years, said, look, you got to do dose for dose accountability. That's the benefit of an IIS. It's not just an inventory system, and that's not really the way that it's designed to work or intended to work. So I'm very sympathetic of the challenges that are out there in terms of the double data entry. I'm not going to enjoy doing that when I do it myself, but at the same time, while I've sat in on a lot of these calls and a lot of this development, I don't know another way to go to get to where we need to be. If we waited for every single HL7 message to come on board, the registry wouldn't happen. And so that's the other side of it for what it's worth. Thank you.
And just to add on to that one, what happens in the practical field and after onboarding like thousands of providers in the different state in my previous jobs with this HL7s and everything, generally what happens that even if you have an HL7 connection a year long, like a year after 2023, we're talking about, you're still going to see the issues that your EHR might not able to send the data properly the way it's served. The IIS doesn't have all the fields that is needed. So you still have to come to IIS has to, document everything that is needed. Otherwise, the dose-to-dose accountability will not going to work. Your report is not working. Your coverage is not working. So you still have to come to IIS and have to do certain things that is going to be a regular process as you go along. Along with that, we have seen people changing their EMR in the middle of the period. Some EMR work for them, some EMR doesn't work for them. We are moving from one EMR to another EMR. Then you have to start the testing process at that time. So, the documenting into the IIS is going to be a very normal day-to-day process from now on. It's not like I will have an IIS and I will have an HL7 first, then I will use it. That is nowhere into the whole national level. Nobody is doing it. Even if those IIS who's been established and in the purest form right now for 20 years almost, they are still struggling with their provider has still asked to do the same exact thing. So that's just the reality of the whole IIS world and the way the data comes to system.
Great, thanks. I think we've had some other discussions prior. There is coming some federal COVID-related funding. So I think as this moves forward, we'll see if there's possible application for some of that to be, to used in these kind of roles. Still early, we don't have a lot of details yet, but as that comes forward, then this is something we'll basically throw in the mix for consideration. So you need another FTE or on a temporary basis or something like that. Can't give you any answers yet, but that's something we'll continue at least to discuss as that new funding comes forward. Just a question here from Joan. She said she may have missed this. When do you expect to start the first phase of testing for HL7? Well, that, as mentioned earlier, the HL7 messaging code will be released this weekend. And then depending upon how you interface. So as we mentioned, this is last week, this is a really good time to reach out to your EHR vendors to inform them that that code is coming forward and you'll want to prioritize this as quickly as possible. And then based on that integration, then the testing begins as Alok outlined earlier. Other questions here. It says, how readily available are your resources as we work with our EMR vendors?
Yep, we definitely have the resources. Like again, like we are getting new fundings and everything, and we are preparing our workforce over here, and we'll definitely do some sort of like a phase-wise rollout to IIS, because again, it's a brand new IIS. All business processes are new. Even if we know what needed to be done, you need what needed to be done. Our business process is lined up. When it comes to like a day-to-day communications and everything, things has to be teased out. Things has to be improvement. So we will pull in a very bigger providers, or maybe some like a variety of providers throughout the New Hampshire and the first get go. And then once we tease out that process within like in a month, so we're going to open it up for everybody to bring in. So just wait for the business process release along with the Delta Guide document over the weekend, because you may want to look at the business processes and think some of those things from your side, what needed to be done. So we may have more discussion once we have the questions after that one. So we just have to wait for that thing that you evaluate your side and we'll evaluating our side. But the HHS is preparing to get a lot of resources in our side to have an HL7 testing with almost every single providers probably pretty soon, in like next couple of weeks actually.
Great.
Hello, for people who are interested in onboarding, will they still be communicating for HL7 through the NHIAS.support email address, or do you have a separate email address for HL7 onboarding?
So we'll keep that NHIAS support account for that one. Because everyone on the same call, what will happen that we're going to phase out that NHIAS support email communication to a ticket-based communication pretty soon. Our ticket-based tool is almost ready, so we'll just have to roll it out and make it as externally facing. Once that is happened, we'll send a notification, but after that, it will be all ticket-based communication, no direct email to any single persons. If you do, then we'll going to tell you that submit a ticket to us so that we can respond to that. So just a very future thing that is coming in, but to make a timely response and have a kind of like a history of communications and have everything, will move to a ticket based communication pretty soon.
Terrific. There's a comment in here about testing at the enterprise level versus the individual level. And what I would suggest, just in the interest of time, is that's probably a great conversation to have offline with a look through the support line. Send him an email, and you can go through that a little bit more. The last question that I have was more of a generalized one here, does my clinic need to make its own COVID vaccine provider agreement to get the COVID vaccines, or do the agreements of my larger hospital organization suffice? Maybe Beth or TW?
Yeah, so I can take that one, Beth. So your larger organization COVID agreement works fine to a certain level. So let me just talk through the nuance of that. If you are going to store COVID vaccine in a separate location than what your larger institution has before, then you need to fill out a second, I think it's part B of the COVID agreement. So basically there's I think 2 or 3 parts of the COVID agreement. The first one is the organizational stuff. And then the next part is where the vaccine would actually be stored. So as we look to bring COVID into medical homes and things like that, that's where you'd want to game out with your larger institution of what that looks like. I've heard some feedback from some hospitals that they're looking at setting up systems in which they would do it much like testing, where people would refer to a centralized site. I've heard others that are talking about trying to incorporate that into medical appointments and things like that. And I'm sure in the end, it'll probably be an amalgamation of probably all of those and some other creative ways. So that's kind of where that's at. So the COVID agreement basically follows where the vaccine is physically going to be stored, as well as a larger organizational level.
Thank you, TW. Well, that's the questions we have for today. I want to thank our panel here, Beth, TW, and Alok, for your time and your thoughtful responses to all these questions. We know this is going to be a trying time for this integration as we've seen in other states, we're going to experience a lot of the same thing. But we will publish some of the information in our packet that will go out to you either later today or early tomorrow. That has the support lines where you can sign up for either the office hours or the weekly publication. So, any closing comments from anyone?
The only thing that I'd say that might be a light at the end of the tunnel is just keep in mind with COVID as we open up to additional data entry for that level and getting that in through Vinny, that will definitely help in terms of demographic data. In systems like these that I've used in other states, once the demographic data is in, it's pretty darn quick to search it, look something up, and put in a vaccine. And so in my mind, the harder lift is without that demographic data in. So I don't know if that helps or not in terms of it. I know it's still extra work. It's still work that you have to do on top of the great work that you're already doing. And for that, I know that we do apologize, but we also believe that this is the best thing that we can do for public health in general. And I just say that's, these types of systems and getting them in place will change hopefully we're all retired by the time the next pandemic comes around, but it's systems like these that if we have in place, we'll be able to shape how we can respond to these types of things in the future and allow for prevention of double data entry and other stuff that we have to do right now in terms of this response. So I know it's a little bit of Pollyanna in me, but just hang in there. I do recognize that it's a lot of work, and we'll try and work with you as best we can. So thank you for all that you do. And sorry, Beth, was there something that you wanted to say?
No, that was perfect. Thank you so much.
Again, thank you very much to the three of you for your incredible efforts over the last year. And we continue to look forward to working with you as we try to reach. So thank you for that. We do have one other discussion item, but thank you to our presenters today for participating. Very much appreciate it. Thanks.
Thank you.
Great. Brian, if you can post the second slide deck. There we go. Okay. So just prior to the meeting, we sent to you all a potential sign-on statement in response to the statewide mandate essentially being terminated last week. The Medical Society leadership thought we needed something that was more specific, that was more goal-oriented. So we've developed the following statement that we sent to you. If you look this over, if your organization is interested in signing on, we will use this for various marketing and promotion activities going into the future. I know numerous organizations have already essentially said that they're going to continue masking, but the two thrusts of this are really to have some two criteria that we essentially urge everyone to follow the CDC and DPHS guidelines that highlight efficacy of wearing masks and slowing transmission of COVID-19 in conjunction with other prevention measures until two things. One, COVID vaccination levels reach community-wide immunity of at least 70%, and that community spread continues at a, quote, minimal level of community transmission, and that those levels are displayed on the NH COVID data dashboards. And essentially, they are to reach those two minimal levels are one, less than 50 new infections per 100,000 population accumulated over a 14-day period, along with a 7-day PCR test positivity levels below 5%. So in the document, you'll see that there's a link to those two definitions to kind of just verify that information. Next slide, please. Again, our objective here are for vaccinations and community spread are intended to allow both communities, businesses, other entities to make more informed science-based decisions based on masking and other policies to help bring a close to the pandemic. But we also understand that there will be situations where individuals should wear masks, such as in large gatherings on a continued basis, or in businesses where it may have requirements for requiring masks. Again, we're also promoting in this message other prevention measures that include avoiding large crowds, staying 6 feet away from anyone outside your household who's not vaccinated, and practicing frequent hand washing. Please look this over as if your organization is interested in signing on to it. You can email back to me. We'll talk more about this, but we hope that this gives the community some and reinforces goals that everyone, I think, is moving for to get much higher vaccination rates and to help mitigate community spread as much as possible. And it's going to take, as we've talked about, it's going to take some time over the rest of the summer to get this. Appears that the emergency use authorization for Pfizer for children 12 to 15 is going to be given to the ACIP or the federal government by about May 1st. And so if the data from that goes well, then we anticipate that probably sometime in the summer we'll be able to start vaccinating that particular cohort. And I know clinical trials are underway for much younger children, down to infants. So we'll look forward to that information, but that does pretend that we can get to all willing communities across state. As we mentioned, just in closing, our big effort over the summer is to be able to target those who are vaccine hesitant, and it will be at every point of healthcare that can have vaccines. So that will be a challenge and something that we'll talk about, as well as some of the other issues raised here today. Again, not seeing any questions right now. We thank you for your participation on a weekly basis. We're a few minutes earlier, so we'll give you back that gift time. Again, thank you for participating and keep up the great work. Take care.